So placenta is a very, very important shield. It shields from multiple things. Now, what you need to remember is that DHEAS is actually being produced by the fetus. And as I said, fetus is a fetal adrenal, or the fetal zone of the adrenal is largely a factory to produce DHEAS. This DHEAS will then be aromatized by the mother to produce estriol, which is the high estriol level in the mother, which is there. At 10 to 12 weeks, there is a production of cortisol, which basically inhibits the hypothalamic pituitary adrenal axis, preventing the female fetuses from being virilized. So theoretically, if you have got no adrenals, it should not have a problem. The major only role is this transient cortisol production, which is there, which becomes important. Now, aldosterone has got no role during the pregnancy because mother is taking care of the blood pressure, sodium and potassium, so it is not of much importance. The placenta has got a very good 11-beta HSG2 mechanism, so that also becomes important. So what does it mean? If you have got a good 11-beta hydroxysteroid dehydrogenase, cortisol and prednisolone will be damaged. They will be destroyed as soon as they enter the placenta. But we'll discuss about dexamethasone later, is not going to be affected in that regards. So if you now look into what will be the choice of treatment for mother for primary adrenal insufficiency, which drug will you prefer during pregnancy?
So ideal treatment that cannot go to the placenta.
So hydrocort or prednisolone will be corrected. But suppose you want to treat the baby, suppose you want to induce the surfactant, or you want to treat him for some cardiac block. For SLE, often they say anti-Rho, anti-La, there may be a cardiac block. In that scenario, you have to use dexamethasone. And when you use that, you should know that there will be a chance of fetal HPA suppression. So largely, I am saying this axis is actually independent of mother. But if you're giving this dexamethasone, it will get suppressed. So once you stop it, after birth, they may develop adrenal insufficiency. So that you have to be very, very cautious about. That becomes important. So day 3 child with DSD, PRADA4, no palpable gonads, 46XX, 17-OHP is 25, marginally elevated, labeled as CAH. Hydrocortisone was given, but reducing doses, the child was off hydrocortisone, but still doing fine. Off steroid, 17-OHP is normal. So now, Dhwani, this is an individual with PRADA4, no palpable gonad. So looks like a XX DSD, which karyotype was also XX. And 17-OHP was just marginally elevated. She is not basically CAH. What do you think could be there? And why am I talking here? Because something in the placenta may have been abnormal. So it could be a aromatase deficiency, because placenta also comes from the fetus. So this placental aromatase deficiency will cause virilization in the fetus and virilization in the mother. So this is some scenario you have to be concerned about. And now she will present it to us with delayed puberty, and there was a history of maternal virilization. So placenta becomes important from that regards. 26-year-old lady with rheumatoid arthritis. Manoj has already discussed that. So Vibha, on prednisolone, pregnancy is there. What will you do?
Sure, that will not cause it. That is the
And prednisolone?
we can continue.
So this also does not cross, and prednisolone is often used more in terms of anti-inflammatory effect. So we can continue prednisolone without any problem to happen in that regards. Now, so you can continue the same. Now, this is the other situation, 28-year-old lady with SLE, pregnancy 20 weeks gestation, fetal heart block. And we are thinking that this is basically because of a transplacental passage of antibodies. Which drug will be useful?
Your strategies should be to treat the child.
Hmm.
We have to give that molecule that can cross if is a development.
So we have to use dexamethasone, which will be preferable in this scenario. Now, Dhwani, in treatment of CAH, like we had this lady who had come to us today with CAH, who now has become pregnant. So what do you think? She's on hydrocortisone. What do you think should be the important management issues in terms of her dose adjustments and other issues? So would their dose requirement go up, go down, remain same, first of all?
Dose requirement first pregnancy will increase CBG. So
Yes. So CBG will go up, dose requirement goes up by 25 to 30%. Second, stress is more. The other thing, of course, is that often because of their high LH state, their corpus luteum is not very well formed. Because they have chronic hyper LH state and anovulation, a lot of other factors are going on. So they may have become pregnant, but their corpus luteum may not be very, very good. So luteal support is required in a very important manner. You have to give progesterone in the injectable and oral preparation, which were going on in this lady. Now, what will happen during pregnancy later half? How will you manage?
during labor or
During before labor also, do you think requirement will further go up?
is so.
Usually there are two peaks, one in the first trimester, second in the third trimester, when your requirements go up. And of course, in labor, you will.
You have to switch on to the stress doses. Then after the pregnancy.
So you have to give stress dose, of course, and then you can come back to the normal dose. Yes. So now what happens at birth? So basically what happens at birth, all the maternal supply, everything is gone. So now baby has to be dependent upon himself or herself to sustain the functions. So essentially, the first thing baby faces as soon as they come out of the womb is what? What is the problem? First problem they face?
Cold environment.
Cold environment. And this cold stress triggers a lot of hormones. You've got trigger of TRH. We all know about the HPT axis, but CRF also increases a lot. So your ACTH levels will go up and cortisol level will also go up. And this cortisol will largely help you in preventing hypoglycemia. That will be a major effect which is there. But also it will also have an effect on the catecholamine production. As we discussed, the blood vessels in the adrenal are basically from periphery to the center. So they will go to the medulla and they will bathe the whole adrenal medulla in cortisol. And therefore you will have more production of the catecholamines and they will become more effective in that scenario. So that becomes important. Now, what happens with this perspective is that your other activities like sulfatase activity and all those things are still there in the fetal adrenal. So there will be a lot of sulfated compounds which are traveling in the fetus and they will continue in the first couple of months. So you have to ask for an extracted sample. So you want to remove that sulfation, that will give you a more reliable product in that regards. Second thing is this 11 beta HSD2 activity is also more in the fetal adrenal. So what will happen for cortisol estimation? Will you overestimate cortisol or underestimate cortisol if you do an immunoassay? Bhani. So 11 beta HSD2 is more, it will produce cortisone. But cortisol and cortisol are structurally similar. So if you are doing basically an immunoassay and you're looking at one part of cortisol, there will be overlap. So you will pick up many of that cortisone as cortisol. So levels will be falsely high if you do an immunoassay. What I'm trying to say is that if you use immunoassay to diagnose adrenal insufficiency in the neonatal period, you may miss a case. If the level is very low, it is okay. If the level is normal, it may not exclude. So if you have a strong suspicion, you should go ahead with a structural assay in which cortisol and cortisone will be separate peaks because there the mass will be clearly different. So structure-based assays will be important in that regards in this scenario. So there is high proportion of sulfated products, high level of cortisone, and that causes diagnostic confusion. In a lot of these cases, whom we label as quote unquote, especially they will come to you with hypoglycemia. When you do hypoglycemia, workup, cortisol is low, cortisol is normal, and then you become really confused. One, whether it is an exhausted response, that because of hypoglycemia of a long term, cortisol is gone. Other could be these problems in terms of diagnostics, and because of that, you can't really confirm. So anybody whom you are diagnosing cortisol deficiency, in the absence of course, CAH or other classical condition, be wary after a month or so, you try to reassess whether this is really a cortisol deficiency, particularly if you think it's a central one. Because central usually happens in the setting of a MPHD. Without that, you have to be cautious. Very importantly there.
present in the cylinder critical sample and that is also sensitive.
Generally, if the levels are low, you are okay. But if the levels are normal, if you have high suspicion, the cost is more. With GCMS and many labs don't do it. So this is just to consider that when you have a very strong suspicion of adrenal insufficiency and your results are variable, then you should definitely go for GCMS. That becomes important in that regards. So GCMS becomes important. So 3-day-old neonate born to a mother with MPHD, penile size is 2.1 centimeters, Vibha, and sodium is low. So you're thinking of a MPHD-like picture. Maybe there's a congenital one. Mother is also affected. Child is also affected. Sodium is low. Cortisol is 120. Is it low, normal, high? First of all, we have to be very cautious. But I would be a bit worried because sodium is on the lower side and that is there. So you need to be worried. With GCMS, it was found to be even lower. So it clearly confirms. Although somebody can say if your sodium is 128, you need to have a higher 550 and above. But now with this 50, we are very, very sure. So if in doubt, always do a GCMS, which will help you out in achieving a right diagnosis in that regard. Now, this is because of the high cortisol, which will be cross-reacting with the diagnosis of the immunoassay. Now, very importantly, you need to also understand that the cutoffs are different for different ages. So as I said, you have got an immediate stress. So in cord, the levels will be pretty low, like less than 100. So now if you go the same corollary, if you go for a premature child, the levels may be low. So same as thyroid, we said, quote unquote, transient hypothyroxemia of prematurity, the levels are low. Similarly here, the cortisol levels may be low and you may got confused in that regard. Now the levels really rise in the first day because of this sudden peak. You have got this sudden stimulation and then it goes down by day 7 as thyroid go down. But they go down to levels which are lower compared to the adult levels. Thyroid levels don't go down. FT4 level will never go down below the adult level. They will be high. But here they go below the adult level, somewhere around 100. And then by around 1 year, they will start rising again. So in the first year of life, be very cautious when you're diagnosing, when you have no other symptoms and your just sodium is 132, 133, you get a cortisol, it is 130, 120, don't get too bothered. You have to be not very much significant. You have to follow up in that regards. Now, if we now look at the other scenarios for preterm babies will have a higher peak, which happens because they are more stressed. Thyroid was a bit opposite. Their rise is blunted. Here the rise is more and it will go off also in the same scenario. So what this means is that although the endogenous production rate is reasonable, in this scenario, the preterms have a much higher production because they need more because of the stress, but there is also no diurnal rhythm which is established. So as I said, do not think about 8 AM cortisol before, let's say, typically around 6 to 12 months of age. Simple random will give you the diagnosis in that regards. And very importantly, if somebody was sick, he was hospitalized, this takes even more longer time. You can all go and have a look at our website, our courses which are available, and the mobile application. So